Welcome to the Better Care Podcast. I'm your host, Dr. Brian Fengler. I'm the co-founder and chief medical officer for EvidenceCare. And with me today, I'm very honored to have Dr. Stan Huff, a pillar in the clinical informatics and interoperability community. To start off with a quick bio on Stan, and we could talk for 30 minutes just on your bio, Stan. Stan is a board-certified clinical pathologist, a professor of biomedical informatics at the University of Utah. He is a fellow of the American College of Medical Informatics, co-chair of the LOINC Committee, co-chair of the HL7 Clinical Information Modeling Initiative, chair of Logica Health, chair of the Fire Foundation. Many folks probably know you, Stan, as the former CMIO at Intermountain Healthcare. And of course, your latest role is as CMIO at Graphite Health, which is something that's very interesting that I'll come back around to and definitely want to talk more about Graphite Health here later on in the podcast. But I guess I'll start off and just say, did I get that bio correct, Stan? Anything that I missed?
You did really well.
You've had a very distinguished career, and I'm so excited to be interviewing you here today. To start off with, I kind of want to go all the way back. I believe you grew up in Utah. Is that correct?
Yes. Small town in Utah.
What were some of the influences growing up that kind of steered you towards a career in medicine?
Early, I don't know, in high school and other things, when I sort of became aware of educational opportunities and job opportunities and other things, there were two things that really interested me. One was computers. And this would be back in like 1970 or something. And computers, the first computer I had even saw was a programmable HP calculator, sort of. But the other thing that I thought about was medicine. So I love computers, and computers, I don't have any explanation for it. It just seems to me that computers have power, opportunity, sort of the opportunity for perfect memory and perfect logic and other things that I just find powerful. And I probably just an inborn error to think about it that way. But then the other thing that I thought about was medicine. And medicine was appealing. It looked like reliable employment for the most part. But also it offers the opportunity to interact with people and to help people live better lives. I mean, it seemed like a worthwhile occupation besides, being good employment, if you will. So
yeah,
those are the things that I was thinking about. Now, another thing that sort of influenced me, and this is jumping ahead a little bit, but I went on a church mission to the Navajo reservation, and I learned to speak Navajo, which is an incredibly different language than all of the other languages that I've encountered. And it wasn't until I learned Navajo that I really kind of understood English and started to understand, I obviously had all of the usual English classes and stuff, and there were grammar and other things, but I saw entirely different ways for the underlying thoughts to be expressed. There are adjectives and adverbs and all these other kind of things, and they're expressed in an entirely different way in Navajo. There were interesting things too, where there are no gender specific pronouns in Navajo. They're just essentially just you and us and they and them, and and that's all there is. And there are also very interesting things that never occurred to me. There's one verb for doing something alone, another verb for doing when two people are doing something together, another one when there are multiple people doing stuff, and another one when they're like groups of people doing and I mean, I just never conceived of, and that led me to think about how we express information and knowledge and data. And in some sense, I think it led me down the path towards interoperability and thinking about the really deep underlying kind of concepts around interoperability.
Yeah, the whole time you're talking about that, I can't help but think about Loink or SNOMED or medical vocabularies that we use to express, clinical items.
Yeah, they're incredible parallels there, and the sort of the deep issues are the same, in terms of and just a recognition that there are multiple ways things can be expressed, both in spoken language and written language, but also in formal models and other things. There are always different ways that things can be expressed, and they have different purposes, etc. The other thing that occurs along those lines is that there are very few absolutes in any of this, in the sense of there's only one right way to do it. It is, and in fact, it is that even the concepts we create are based on what we want to accomplish. So, I mean, there are essentially an infinite number of things that you could say about the universe, but we pick certain things and certain actions and activities to give names to, and then start talking about them So anyway, I'm sort of headed down a rabbit hole here, but it's to me, it's just a wonderfully complex fractal sort of world. And I mean, it's just wonderful to work in that space, I guess, is the way I think about it.
Yeah. As part of your medical training, you went on to be a clinical pathologist. Anything that sort of steered you in that path as a specialty?
That was kind of practical and pragmatic, if you will. So when I was a senior in medical school, I started working with Homer Warner, who was one of the founding fathers of medical informatics. And so I decided as a senior in medical school that I wanted to go into medical informatics. Now, it wasn't even called medical informatics back then. It was like, computing or medical computing or biomedical computing or biomedical physics or other things. But I was already committed in the match. So I went to University of New Mexico and did a year of internal medicine that I was committed to. And I wasn't confident that I could make a living doing medical informatics. So I thought I better have a medical specialty that I can fall back to just so I avoid unemployment. And the most computerized specialty, and in many ways still is the most computerized specialty, was laboratory clinical, clinical pathology, laboratory medicine, essentially. So that's how I got there. It was, I enjoyed it anyway, because instrumentation and numbers and then all of the issues about how you measure things and uncertainty in measurement. Anyway, all excellent background anyway, but that's unemployment insurance in a sense that I went into clinical pathology.
So had a love for computers coming out of high school, knew you wanted to do something in clinical informatics. What were some of the first kinds of projects or things that you were working on? Was it during residency or was it after residency that you really started diving into the field?
Well, I did projects during my residency. So my clinical pathology residency was back with at the University of Utah, where I also got my MD degree. And one of the first projects I worked on actually was creating an interface between a blood bank system in the laboratory and the hospital information system, which was called HELP at that institution. I was a medical resident, and there was a student by the name of Ron Sadi, and we worked together to create an interface to transfer blood bank information from that one system to the other, and that was a fascinating project. The straightforward information about what blood units were available for this patient and that kind of stuff, but the more interesting information was blood typing, especially related to transfusions, where you're looking for the antigens that a person has and and especially those who have received a lot of transfusions, when they start forming antibodies against Duffy and Kell and all of the, less common, the other antigens besides ABO and RH, Anyway, that kind of project. And then there were other projects that were around developing terminology and managing terminology, and then got involved in decision support application development, primarily with Peter Haug and Al Pryor and Reed Gardner and others who were there at Intermountain.
Yeah. So at Intermountain, you guys had for a number of years a homegrown EHR that many considered ahead of its time. What were some of the cool things that you guys had within that EHR that, maybe some current EHRs are still not even doing?
Yeah. The biggest thing that comes to mind is the system was called HELP, and that stood for Health Evaluation Through Logical Processing.
Okay.
This was before relational databases. Basically, it was a time when you made your own databases, if you will. HELP had a unique database, but the thing about HELP, sort of at a big picture level, was that the system was designed entirely to help clinicians take better care of patients. And I draw that distinction with what I think motivated a lot of the other later EHRs, which were around patient administration, patient billing, sort of the financial and administrative aspects. The HELP system from the very start was set up to collect data through devices so that it could automate data collection, so it would save time for nurses and clinicians. It was about creating interfaces so that lab data would be available at the bedside to clinicians. And then it was about decision support. So very early on, it was, for instance, once we had lab data, then the system was immediately set up to notify people about, if you will, panic or urgent lab kind of activity. So it would notify you that this patient had a low potassium and they were on digoxin, and that could lead to fatal arrhythmias if you weren't careful, that kind of thing. And there are just any number of those things then that, ultimately I got involved in, some of them later, rather than earlier. But that was the main thing. And that I didn't realize sort of how jaundiced and biased my my experience was towards the value of clinical decision support and what it can mean to healthcare. And when I say decision support, I'm not talking just about diagnostic decision support, but it's about sort of everything that you can do to aid the care process. That could be just managing chronic anticoagulation in patients, or it could be making it easier for patients to make appointments, or all of that to me is decision support. It's helpful, things where the computer is actually thinking in the background and prompting and helping people to do the right thing. I guess anything could be considered decision support, even just aggregating data and being able to display it at the right time to a clinician. But I usually think of it as things that where the computer is doing things that either people can't do or don't do well, and that lead to better healthcare. And that's sort of been a really common principle in my career and my thinking for, ever since. And I realize even now that some people don't see the value and don't believe in the value, and that's okay. But I don't think it's true. And I always hope to get an opportunity to talk to those people and help them understand, the things that we can do better if we have the computers aiding us in that work.
Now, you were at Intermountain for a number of years, and obviously Intermountain is very well respected as a organization that delivers high quality care to its patients. How do you think Intermountain realized that? Was it your health IT? Was it the mission of the organization? Was it the people? Like what are the primary factors that you think went into making Intermountain Health a leading organization from an outcomes perspective?
It was a combination of things. So there were visionary individuals there: Homer Warner, Reed Gardner, Al Pryor, Paul Clayton, others who just had the vision of what could be accomplished. It's also, though, incredibly important because it aligns so well with Intermountain's mission and vision. And what I mean by that, Intermountain was formed in 1975, and the way it was formed, the Church of Jesus Christ of Latter-day Saints had 20 or so hospitals where they're providing healthcare, and then there was a conscious decision by the church to divest itself. It said, we want good healthcare to happen, but we don't want our leaders to just be spending all of their time on the boards of healthcare organizations or financial organizations or anything else. We want them to be out with the people, doing work. And so it was formed as a not-for-profit company with the mission of basically providing the highest quality healthcare at the lowest reasonable price. Obviously, the organization had to be sustained, and so it was an interesting culture at the level of the corporation, because the corporation, and this a lot of this, for instance, was gleaned from conversations with Brent James, who's another really important influence at Intermountain. But he said it was fascinating. You go to a normal, and it's still true today. Go to a normal a normal board meeting for a healthcare corporation, and they're talking about, how are we doing on revenue this year? What's our revenue goal? What's our, are we going to have capital to build a new building? Whatever. Intermountain's board meetings were, how are we doing on quality? Are we taking the best care of patients we can for the money that we're receiving?
Yes.
The whole idea that, after all, we're spending sick people's money, so we need to be careful, and we need to use every capability that we have to try and take better care of people. And that mindset, evolved into the mission statement of Intermountain, which is helping people to live the healthiest lives possible. Mm-hmm. So that becomes inclusive of preventive health as well as, acute care and ambulatory and everything. It's everything you can do, exercise programs, whatever, everything you can do to help people live the healthiest lives possible. And so that corporate culture just fit perfectly with sort of the forward-looking, innovative thoughts, of the informatics leaders at that time.
I love that. Focus on the quality and have that be the primary, topic of discussion and in the corporate board meetings. That's amazing. I want to shift gears a little bit and get maybe into the weeds on some of this interoperability discussion. And obviously you serve on a number of committees, but I think there's a lot of confusion out there. People hear fire and LOINC and SNOMED, and they don't really understand how to think about those as separate entities and how they work together. And I actually saw an article that you had written previously where you did a really good job of sort of talking through, what is fire versus LOINC and SNOMED, for those that are interested in this topic.
Some of these ideas go back, I think when I first started thinking deeply about them were influences by Clem McDonald when he formed the LOINC committee. And, the first meeting of the LOINC guys wasn't called LOINC. I can't even, we just got together. Clem came up with the name for LOINC because it's like Clem, kind of provocative and fun and innovative. But what it was about, what LOINC was about was that we had HL7 version 2, which was not in broad use yet, but it was a standard and people were using it. It was in use. And that is all about structure. And I mean structure in the sense of like programming programming language structures, where you have a data structure, if you will. And so HL7 version 2 is providing the structure, but people that were now creating HL7 interfaces said, what codes and terms do we use in those standards in order to actually communicate information? I mean, so we've got a result record, but everybody basically was making up, they had everybody who would install a lab system would make up their own names for all of the lab tests for hematocrits and hemoglobins and glucoses and potassiums and sodiums. And some would spell out the word and some would just have an abbreviation and, some would use a number, et cetera. And so LOINC was created out of a desire to have people, use a standard code in their system, and then that could be transmitted. And then you didn't have to do all of these one-to-one, many-to-many mappings between systems. But what, sort of getting back to the point that you asked about, what occurred to us at that time is that the terminology had to work synergistically with the structure. And knowing the structure helps you to know how much information to put in a code, or whether you wanted to use multiple codes or the other aspects of the structure to represent that information. So for instance, very early on we said, well, we're not going to make LOINC codes that say stat glucose or stat hematocrit or stat something else, because we know in the HL7 structure there's a field for the priority. So that stat, and we know that that's going to be transmitted in the message. And so we're never going to include that information. Likewise, you could have made LOINC codes that said Dr. John's pain clinic elixir level or something. I mean, but again, we know who ordered it. We know who it's going to. That's information that's elsewhere in the message. And so there's an early rule. It says we never put, a clinician's name in there. And then the other thing that is less clear and comes back to many ways to say things is that just thinking about something like glucose levels, a glucose level in one sense is always a glucose. I mean, you put the sample on the machine and it figures out that the glucose is, 120 or 130 or 100 or 80 or whatever the glucose level is. But then when you look at actual patients, lab systems, they have lab tests that are named random glucose and fasting glucose and pre-op glucose and post-op glucose. I mean, they have all of these different glucoses. And then you have, glucoses by finger stick and glucoses, and so you realize that, there's a glucose level, and then there are all of these specific things that are actually really important for the interpretation of the data that say whether it was random or fasting or finger stick or done by glucometer or whether it was done by the best instrument in the laboratory. And those can literally be done both, two ways. That is, you can have in the HL7 message, you can have a single code that everybody uses for glucose level. And then you can have additional information in the message that gives you the context. So the additional information would be in a different field that said whether this was random or fasting, a different place where you could say what kind of instrument it was done with, any kind of precondition, whether it was, you might even be doing, exercise glucoses or something, And so that representation, and LOINC made a very explicit decision to support kind of both styles. So LOINC has the ability to say fasting glucose is a single code, or just glucose with another concept in the message that says this is a random, status, whether it's random or fasting, et cetera. There's that interesting interplay. And I think the term that I've heard people talking about it now, actually some fun discussions going on and a new collaboration going on between LOINC and SNOMED. And one of the discussions is, how do we more actively make sort of a unification of that information model structure part and the way that we use the codes? And I'm going on too long in this vein, but the thing, for instance, in SNOMED is that SNOMED distinguishes between the name of the procedure versus the name of the result that comes from that procedure.
Mm-hmm.
So SNOMED has codes that say hematocrit, and the real meaning of that is it would be used like if you wanted to say what are the steps that you do to get a hematocrit. You draw a sample, you spin it down, you measure the volume, the volume of the clear versus those procedural activities. And then there's a different code, quote unquote, an observable in SNOMED that has to say, this is the name of the number that was achieved by the result as a result of that process. I did all of those process steps and I ended up with a number of 49% for the hematocrit. And the point is that if your terminology is agnostic to any information model, then you'll end up with a whole, and as you might guess, that means that there are essentially things that look to an unbiased observer would say, well, geez, this whole hierarchy over here in the procedures looks almost identical to this hierarchy over in the observables.
Mm-hmm.
And so the idea is coming out in that discussion that, hey, if we can say we're anticipating this code could be used in an order record or in a result record, when hematocrit as a code shows up in an order record, we know you're asking us to do that test. On the other hand, when it shows up in a result record, we know that's the name of this 49% that is the thing that I'm going to use clinically to make decisions. So I've gone on way too long, Brian, about that interaction between the two parts. But
yeah. No, we could talk about for hours on that in the weeds of all that. One of the questions that did come in through LinkedIn earlier this week was, and you're obviously very involved with the FHIR standard, but the question was, why is it taking EHR vendors so long to adopt FHIR?
I think there are many reasons. And I would say probably the most important are sort of business, cultural, social issues. I don't mean to denigrate anybody in what they're doing, but another one of the sort of truths of things about standards, you could ask, well, in some logical sense, standards make so much sense in terms of what they can save and do and enhance society. The practical truth, though, is if you're only dealing with sort of one organization, it's easier to just make up your own codes. It's way easier. Mm-hmm. If you use standards, you have to figure out what the standards mean. You have to figure out what you used to call this thing. Now you're going to call this other thing, essentially making mapping between your local representations and your standard representations. But as soon as you start talking to like more than one other organization, if you're having to send lab data to your EHR and also to public health, and you have to share it with the insurance company and whatever, you quickly realize now standards have a real practical value. But too often implementing systems is driven by how fast you can get it done, and their payments depending on when you get this thing done. So people, just the common tradition forever has been people just make up their own codes, and they may start with a starter set, but then they quickly modify that and change it. And so it's been tradition. But the other thing is that, and this comes up in other things, that the best action is not financially incentivized. The best behavior is not financially incentivized. So companies that have large market share, why do they want to be more interoperable with other companies? Why do they want to support FHIR? There have been arguments that just knowing the way, if you will, the attributes of information or data and the way that they're shared is intellectual property, and they wanted to protect that intellectual property. Now, I don't think that's in the best interest of society or of patient care, but those are some of the things. I mean, if you're in a dominant market position, you don't have a financial incentive to support FHIR or ONC standards or other things. And so, that's why I'm so grateful, if you will, for the regulations that move towards much more open access and use of the data, and especially both the FHIR standard and the terminology standards, LOINC, SNOMED, RX norm, UCOM for units of measure, all of those things love that those things have been mandated, and they're a tremendous step forward. Another aspect to that, many of the systems have literally were architected 30 years ago or more.
Mm-hmm.
Now, the fact that they stood up for 30 years means that they did a pretty good job of that. At the same time, I think, looking at systems that are organizing the information into 4,000 to 6,000 tables, it's not intuitive how you get that to be fire resources, for observables and for patients and other things, and so it's real work too. It's not that people are just not motivated. It's also that it's real work, but it's worth it. I just hasten to add, it's really worth it. But I think that's some of the issues that I see in how long it takes. But people shouldn't be surprised either, because again, the first versions of ASIL 7 that were really implemented were created in 1992, 93, in that time, actually earlier than that, but that's when people started actually using them. And I would guess that it took almost 15 years before you started seeing like 90% of healthcare organizations using that. So, I mean, traditionally, it's taken that long. Change management is just incredibly hard.
Yeah. Well, I do want to talk a little bit about Graphite Health, but before I do that, question that's come in from the audience is, what would be sort of your ideal vision for interoperability? What do you see the possibilities of that leading to?
Here I'm going to wax philosophical and stuff. I mean, it's amazing. My personal motivation in this area really comes from the fact that we're not providing good care for patients. I mean, really good studies have shown that somewhere between 200,000 and 400,000 people a year die of preventable medical errors. And you can look at the research article that came out a few years back out of Johns Hopkins University, published in the British Medical Journal, documented that, and other similar studies that have been done. So, and verified by my own experience, I might say, in my own case, as well as family members and others, there are just a whole bunch of preventable medical errors. I mean, you put that into perspective, that means today, over 600 people are going to die today
Wow.
of preventable medical errors. That would be like 2 airliners crashing and killing everyone on board every day. Somehow that hasn't caught people's attention. We've just become accustomed to it. And there's also a lot of, it's those other bad doctors that are doing that. But when you get into it, you find that no, sort of that happens to everybody because they're tired, or they get mixed up, or they were on call all night and didn't get any sleep, or it's just things that you could never remember anyway, where a computer you have to have a computer because none of us could remember all of the potential drug interactions or other things like that. So that's the motivation. But the idea is that if we had true interoperability, plug and play interoperability, then what would happen is people would start creating those kind of very useful applications that help take better care of patients, that look for occult sepsis in the emergency room, or that help diagnose and manage deep venous thrombosis, or applications that manage chronic anticoagulation, or applications that suggest the very best antibiotic to use, when you have a suspected infection and a suspected site of infection in a person 53 years old, blah, 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 and those things would grow up. And the thing that would be very different is that if we had true interoperability, you could make that application once and then everybody could use it. I mean, not for free. I'm assuming people would still, they would make that, create that kind of knowledge, and they would be able to then use it everywhere. And one of the remarkable changes would be, it would be available in 200-bed community hospitals. It would be available in every physician's office and every nurse practitioner's office, et cetera. And today that's not true. I mean, you can get there, but I mean, talked with companies and that are doing this kind of activity. And you guys, you could even comment on this part, but they developed the knowledge. And then this wasn't your company, but another company that said, hey, we have these things that we've proven to be useful and valuable. And when we take them now to the next hospital, we spend typically 6 months. They have 10 applications that they're doing. So it's not just a single application, but we spend 6 months wrangling the data to be able to support that process. Mm-hmm. And that's not a scalable process. It means that that's going to be limited to people who can afford it and who have the time and resources and the informaticists and other people who can do that. And we need to get out of that. We need to get into a truly interoperable situation. Well, if we do that, and things are now shareable without modification, then it changes dramatically other things. For instance, you think about the impact on medical schools. The body of knowledge now is residing in executable programs. I mean, when I say executable knowledge, I mean it's a program that I don't have to think about. It's running on every patient who's seen in the emergency room, and it says, oh, based on the fact that this patient has had some nausea and vomiting, a little fever, they're a little bit hypotensive, you need to be thinking about whether this patient has sepsis or not. Mm-hmm. You need to order a white count, you need to order a lactic acid, you need, and it's going to interact directly in that. And so that becomes now shareable everywhere. And what can happen then is that organizations and people would get together, and you'd have a group of people who are working on how we best treat diabetes, how we best treat heart failure, how we best treat asthma, how we best treat Hashimoto's thyroiditis, et cetera. It becomes like weather forecasting. Over our lifetimes, we've seen progressive incremental improvement in weather forecasting. And one of it is, greater and greater accessibility to data. But the other thing is, with that data, we create new knowledge, and then we can create ever better prognostic applications about that. Mm-hmm. And so every disease would become like weather forecasting. It would just get better and better. And the knowledge we have is expressed as knowledge in executable programs. And we make, it would change too, so that, the way that we compensate or recognize clinicians for research by peer-reviewed applications, it would change so that people get recognition for creating new and better knowledge representation and execution. The actual creation of that executable module becomes an academic credential, if you will. Mm-hmm. There's a lot more to think about there, but I think we're at a critical time that fundamentally we can change the history, about the way people practice medicine. And I'm quoting really sort of my heroes like Larry Weed, whose book about medicine in denial describes, a lot of the impact that we need to have that we really owe society if we're going to take serious our commitment to improve the health of people in the world.
That's great. Well, let's dive into Graphite Health. So, I know about the company, but would love to have you tell the audience sort of how is Graphite Health formed? What's the vision for Graphite Health? Why don't we start there?
So Graphite Health was formed by 2 or 3 founding individuals. Reese Robinson, who worked at Presbyterian Hospital in Albuquerque, Dan Lillenquist at Intermountain Healthcare, and Matt Abrams, who is a venture capitalist guy, actually. But the idea between Graphite is that it would be about creating the kind of interoperability that we're talking about, that we would have a standards-based representation, if you will, a single preferred way to represent a particular kind of data. We would adhere to all of the standards, to FHIR, to LOINC, SNOMED, all of that sort of stuff. And we would create an environment where people could create applications and access data through a truly semantically interoperable FHIR API that would help realize the part of the vision that we've been talking about, that people could create applications, they could be certified as Graphite compliant, if you will, and that would make a marketplace for those applications. And then complementary to that, Graphite produces a platform that those applications can use, because we found, at least so far, kind of going back to some of our early conversation, the FHIR services as they're provided today aren't really adequate to do what people want to do. And so Graphite would produce a standardization process based on standard information models and standard terminologies. We would standardize, data from wherever we could get it, whether that was a lab system or a pharmacy system or an EHR system. And those applications then would be able to access and use that data in a truly interoperable fashion. And so that's sort of the seminal idea behind that. But it goes beyond that. Once you have that standardized data, for instance, you can imagine, boy, that would make public health reporting so much easier. It would make it so much easier to participate in clinical trials. It would make it so much easier for people to aggregate data for analytics and population health. It makes it easier if I'm being seen at two different healthcare organizations because they can both see all of my data and not have to translate it or do anything. I just access from two different endpoints, and I can see the trend of glucoses that you had at Intermountain and glucoses that you had at the University of Utah, et cetera. So that's the quick story on Graphite. Obviously, there's a lot more that we could say about it. But the current member systems are Intermountain, Presbyterian Health, Kaiser Permanente, and SSM Health. SSM centered in St. Louis.
And so all of those health systems have agreed that they're going to integrate into Graphite Health, and that then Graphite certified applications could operate in a sort of plug and play fashion in those environments.
Exactly. That's the vision. That's
yes,
exactly
very interesting.
I mean, I would throw in a couple of things. Graphite itself would not make the applications because we see that as competing with the people that we're trying to enable in that ecosystem. The other thing is that, and this could change over time, but the current best thinking is that, we would make the Graphite platform inside of the system's control, inside their firewall, if you will, or inside their security, so that they have total control over the data. They can share it with who they want to share it with, not share it if they don't want to share it with anyone, but still have the advantage of having truly interoperable data and applications.
And just from a little bit more that I know about it, which additional points that may be interesting to the audience, I believe it's set up as almost like a public utility and that it's nonprofit. And
yeah, it's nonprofit, probably more detail than people want to know, but it really, what's happening is that it's financed right now through debt financing. In other words, the governing member organizations are making loans to Graphite that Graphite will need to pay back as we get further developed and have a revenue stream based on sales of applications in the marketplace. But nonprofit, exactly as you described, a community benefit type of organization. And our model there is with Civica, which is a company that is working in the area of providing economically feasible generic drugs for folks. So,
well, Stan, we have another question from the audience here, which is, what is the single most important or exciting thing that you would like to accomplish with Graphite Health in the next 3 years?
Just to establish feasibility. We need to actually create the platform, standardize the data, work with some companies to create applications that we can put up into the marketplace, see those things actually work in the plug and play way that we said, that we don't have to do special mappings at every organization or do special changes to the application as those are implemented. I mean, that to me is the most exciting thing, is to see this actually working. Probably will forever be naysayers, but I think we can overcome a lot of naysayers if we can see practical use, and people will, and we'll get past the issue of whether this is really possible. Some people would argue it's not even really possible. It's so hard that we can't do it. That's a whole nother conversation. But I think that's the most important thing, is to prove that we can do it and start recognizing the value of that in improving patient care.
That's great. Well, probably a great place to end there, Stan. Really appreciate you joining us, and couldn't be more thankful for all the work that you've done over decades to really lay the foundation within this field that many companies are now able to evolve from there. Really appreciate the conversation today, and thank you for joining us.
Well, it's just been a pleasure. Brian. Thank you for inviting me. I love an opportunity to talk to people, and it's been great. And I'm just grateful for all of the people that I've had a chance to work with that have been just exceptional mentors and friends to me. Ed Hammond, Clem McDonald, as I already mentioned, the people at Intermountain, many other people, including Mickey Tripathi and others that are, working in national. They've just been great friends and great mentors for me. John Halumka. I'm going to forget a lot of people, but I'm so grateful for the people that I've known and had an opportunity to work with in this area. And thank you so much for this opportunity.
Absolutely. Great seeing you today, Stan. And thank you for everybody who joined us live. Of course, we'll be posting this on all the various platforms for podcasts, so folks can listen to us there as well. So thank you.
Thank you. It's been a pleasure.